I am Colleen Elby. I am a supervising attorney at Disability Rights Texas. Appreciate you all joining us today. I'm still not really sure how or why I get the privilege of being a part of events like this that are bringing together the best and the brightest in national FASD research and advocacy. And really, today's event is just the start. I do want to take a moment to let you all know that we are planning an all-day event on May 6th, 2022. Still really weird to hear 22. But that all-day event is going to be in Lubbock, Texas. We are going to have a virtual component for those that either cannot travel to Lubbock or for some reason don't want to travel to Lubbock, Texas. I don't know. But that event is going to showcase some of the distinguished guests that we have here today. But then we're also going to be bringing in local experts together with FASD families and providing resources for those families. There have been other similar events to that have been successful across the country, and again, pulls in the best of the best. We hope that with some of our amazing sponsors that we've got on board, we're just going to have a great day of learning and sharing. We not only hope that you can join us on May 6th next year, but if you are interested in being a sponsor for that event or want to contribute in any other way, you can reach out to me directly. I'll put my contact information in the chat box in a few minutes, and that would be the best way to get involved in that if you're interested. I do want to take a moment to introduce our host for today. Dr. Rajesh Miranda is a professor of neuroscience and experimental therapeutics at Texas A&M University Health Science Center, College of Medicine. And Dr. Miranda, along with Linda Kagi, are the co-chairs of the Texas FASD Alliance. Linda, can you take a moment to talk a little bit about the Texas FASD Alliance for us?
Hi, everybody. So glad everyone is here, and I'm just honored to be a part of all the work that's going on in Texas and around the country to better help families and individuals with an FASD. As you said, I'm the co-chair along with Dr. Rajesh Miranda for the Texas FASD Alliance, and we are hosting the meeting today, so we're real honored to be able to do that. In Texas, we have had several areas of focus. We have focused on of course, policy, trying to get policies changed and put in place for FASD. But we also have education component, which is really important to us. So we try to educate around the country with whether it's webinar or in person for people with an FASD. So just a couple of things that we do. We have more than that. If you're interested at all, you can contact us at fasdtx@gmail.com, fasdtx@gmail.com. And we're really looking forward to seeing everybody at the conference and being involved in that as much as we can in 2022. So thank you again, Colleen, and thank you everybody for being here.
You bet. Thank you, Linda. And I did see that the email is in the chat box if anybody didn't get that. So I just want to quickly introduce the speakers that we have on deck for today. We first have Dr. Douglas Waite. He is the Division Chief of Developmental Behavioral Pediatrics at Bronx Care Health System and Assistant Clinical Professor of Pediatrics at Mount Sinai Hospital. He serves as Vice Chair on the board of NOFAS and serves on the FASD Task Force for the American Academy of Pediatrics and is a member of the AAP Executive Council on Foster Care Adoption and Kinship Care. We have Dr. Kenneth Lyons-Jones. He is a world-renowned pediatrician and researcher in the field of birth defects. He's authored hundreds of scientific journal contributions and is actively involved in research, clinical services, training and education, and policy focused on the clinical delineation, diagnosis, and prevention of adverse pregnancy outcomes and birth defects resulting from environmental exposures. We also have Dr. Larry Bird here with us today. He is a professor of pediatrics at the University of North Dakota School of Medicine and Health Sciences Center, and he's the director of the North Dakota Fetal Alcohol Syndrome Center. Dr. Bird's research encompasses areas such as FAS, autism, sudden infant death syndrome, and smoking prevention in schools. I told you that we had a great lineup for today, and I wasn't lying. Before I turn it over to our moderator, if you have any questions, please be sure to put them in the chat box as we move along. We'll be sure to get to those as many as we can of those. Dr. Miranda is going to be reading those questions to our presenters. And before I turn it over, I'm going to introduce you to our moderator for today. That is Tom Donaldson. He is president and CEO of the National Organization on Fetal Alcohol Syndrome. And Tom, if you could take a couple minutes before we get started with the presenters to talk about NOFAS and kind of some of the things that you're working on and your agency is working on.
Colleen, thank you so much. And thanks to you and Disability Rights Texas for organizing today's effort and your leadership in the field. I also want to thank Dr. Miranda and Belinda Kagi for their leadership with the Alliance. At NOFAS, we're quite familiar with Dr. Miranda's research as it helps to inform all aspects and all facets of the work that we do. So we're thrilled to be here. I'm thrilled to be listening, even though I've been involved in this field for a long time. Doctors Bird, Jones, and Wade are mentors to me and all of us who do public health and are trying to raise attention and awareness and investment for FASD. Just very briefly, the National Organization on Fetal Alcohol Syndrome, or NOFAS, we're a public health advocacy organization based in Washington, D.C. As I say, try to raise awareness, try to make sure women and their partners and anyone who may need information about the risk of prenatal alcohol exposure can find someone to talk with and be connected to what we know about PAE through NOFAS, and equally importantly, those individuals and their families and caregivers who live with FASD and quite often maybe are desperate for resources, for finding services. And so I want to let everybody know at nofas.org or contact me directly should you need information, a referral or resource on FASD. NOFAS has a 33-member affiliate network around the country as we continue to expand. We often, of course, have the best information in their states and regions. We also have an information and resource clearinghouse that can help you. Lastly, I do want to mention just very recently, within the last couple of weeks, in the United States House and Senate, the FASD Respect Act, or more formally, the Advancing FASD Research Services and Prevention Act, has been introduced in both chambers. There have been FASD legislative efforts over the last 25 years, but I've never seen anything like the interest and the enthusiasm that I see now, both on Capitol Hill and around the country among advocates, professionals, researchers, everyone who cares about this issue. So we're hopeful. There's a lot of work to do to try to push forward the research, get it passed, and get greater support for FASD within agencies at the Department of Health and Human Services and Education and Justice. I'm sure you're here today as to why those areas and so many others have implications for FASD and need to be addressed more comprehensively. So thank you very much. Now, I believe we're going to begin, and please, gentlemen, correct me with Dr. Bird. So Larry, it's good to see you, my friend. I always, as I say, am fascinated with the latest data, the latest research, and the latest goings on that emanate from North Dakota, where you're based, but have a far reach throughout the country and even globally. So looking forward to hearing you again.
Actually, Ken, Dr. Jones is going to go first. So
he's going to go first. Well, so
I'll defer to him. Okay.
Well, Ken, look, I know every morning you wake up a young man thinking about FASD and whether it's stigma obviously diagnosis, other research that that helps us along. So take it away, Ken. Oh, you're muted. We can't hear you.
All right, I think I'm unmuted and I think I'm set. Is that right? Not quite. There we go. So as this first slide shows, I'm going to talk this morning or this afternoon on the fetal alcohol spectrum disorder, its prevalence, recognition, intervention, and the justice system. And I'm going to start with prevalence. This is from a study that was published in 2018, 2019 in the Journal of the American Medical Association on prevalence of fetal alcohol spectrum disorders in 4 US communities. And those 4 US communities included 3 rural communities in the United States and 1 urban community. And the 1 urban community was here in San Diego, where I am located. The prevalence of this disorder, and I want to just get away from this. The prevalence of this disorder across these 4 US communities was 1.1 to 5%. And what that is saying is that in some of these communities, the prevalence of this disorder was 1 in every 20 live births. So we're talking here about a disorder that really is just as common, just as frequent as autism spectrum disorder, and probably twice as common as autism spectrum disorder in many parts of this country. In San Diego, where I am, the prevalence was 2.3% in first and second grade students in the San Diego Unified School System. We are the 2nd largest school system in the state of California. So in our state or in our community, it was 1 out of every 44 live-born babies. And there are approximately 200,000 new cases of FASD per year in the United States. And I'm sure Larry is going to talk a lot more about that kind of issue. I want to see if I can. I want to, right from the beginning, tell you what we believe is the criteria for risky prenatal alcohol exposure, because I think I'm going to surprise you with this. And this is data for, or this is the criteria that was set forth by the National Institute on Alcohol Abuse and Alcoholism, which, as I think you probably know, is an institute of the NIH. And they have said that the criteria for risky prenatal alcohol exposure is equal to or greater than 6 drinks per week for equal to or greater than 2 weeks during pregnancy, or equal to or greater than 3 drinks per occasion on equal to or greater than 2 occasions during the pregnancy. So the point here is that when we talk about this disorder, we are not talking about a disorder that occurs in people who are severe chronic alcoholics. Now, severe chronic alcoholics also clearly have a problem as far as this is concerned, but the majority of people who give birth to babies with this disorder are not chronic alcoholic women. They're women who drink at a much lower amount of alcohol. And they're women who really do not believe they are drinking at a risky level. So these are women like women who are lawyers, women who are pediatricians, women who are business people, who come home at night exhausted after a busy day. They sit down to eat dinner and they drink a glass of wine during dinner. And they do that 6 times a week for equal to or greater than 2 weeks during the pregnancy. And suddenly 6 weeks along into this, they find out they're pregnant and they think, oh my gosh, and they really have been drinking during that first 6 to 8 weeks of their pregnancy prior to the time that they knew that they were pregnant at a level that clearly is risky as far as this disorder is concerned. Now, I want to tell you, in the same study that we looked at the incidence overall, or the prevalence overall of this disorder, we looked at the prevalence of this disorder in the San Diego Regional Center. The San Diego Regional Center is a service which provides a wide array of services for individuals with developmental disabilities throughout the state of California. And there are virtually in every large population base in the state of California, a regional center, and you have similar type programs. I know in Texas, I was talking to Colleen about this, Colleen Elb, and she has told me that there is something there that is similar called local intellectual disability authorities throughout the state of Texas. So this is a similar kind of place. And what we found there was that the prevalence of this disorder in the San Diego Regional Center was 28.8%. And of greatest importance here, I think, is that not a single one of those children who we identified as having fetal alcohol spectrum disorder, not a single child was previously reported by their parents to have FASD, and not a single one of these children was diagnosed by any of the regional center physicians as having an FASD. So this is an invisible disorder in many, many situations. And as you see here, that clearly was the case. Now, I want to talk first about the fetal alcohol syndrome, and I'm going to talk very briefly about this. And I then want to talk very briefly about alcohol-related neurodevelopmental disorder, but this will be very brief. This is the fetal alcohol syndrome. It was described in 1973 here in the United States. It's associated with growth deficiency, and that includes prenatal growth deficiency, meaning that these children are small at the time of birth. They were growth deficient postnatally as well, meaning that they continued to grow poorly after birth. They had microcephaly, or a small head, indicating a smaller than usual brain. They then had very short palpebral fissures. The palpebral fissure is the window that our eye looks out of. They have long, smooth philtrums, thin vermilion borders, and neurobehavioral deficits. Now, I want to show you a couple kids with this, but the first one I'm going to show you is my third-born son, who does not have fetal alcohol syndrome, but just to show you, I think you can see, I hope you can see this arrow, but the palpebral fissure goes from the inner corner of the eye to the outer corner of the eye, and that is short in children with the fetal alcohol syndrome. And then the other, here's a newborn baby with this, and obviously you can see how difficult it is to measure palpebral fissure size in a newborn baby, because those babies, generally speaking, are crying or sleeping. They have their eyes closed and you can't measure it. So you do something like what I was doing here, which is totally wrong in terms of measuring the palpebral fissure. But again, this measurement goes from here to here. You can see there's an eye back here, but that palpebral fissure, that window that the eye looks out of, is clearly small. Then in addition to that, the other cardinal facial feature of this disorder is a long, smooth philtrum and a thin vermilion border of the upper lip. This is my second-born son. He doesn't have the fetal alcohol syndrome either, but to just show you, the philtrum goes from the base of the nasal septum here to the red part or vermilion border of the upper lip. And you see he has these vertical ridges here on his philtrum, and you will find out for yourself that if you take your index finger and run it over your philtrum here, you will feel that you have these vertical ridges. And then he has this beautiful Cupid's bow configuration of his upper lip. And you see in a child with the fetal alcohol syndrome, this is a Native American child, you see this long philtrum, which is smooth, it lacks those vertical ridges, and the upper lip is very smooth and thin, and it lacks that Cupid's bow configuration. And you see the same child here as an adult, and you see here that she lacks these ridges, these vertical ridges, and she also continues to have this smooth philtrum lacking the Cupid's bow configuration. And here is a white child with this disorder, and you can see this long, smooth philtrum, no vertical ridges, and the thin upper lip that lacks that Cupid's bow configuration. All right, that is the fetal alcohol syndrome. As I said, it was described in 1973. And then in 1996, the Institute of Medicine of the National Academy of Sciences looked at a huge amount of data on this disorder, and they demonstrated that prenatal exposure to alcohol causes a spectrum of defects. And at one end of that spectrum is the fetal alcohol syndrome that I just described to you. And at the other end of the spectrum is what's called alcohol-related neurodevelopmental disorder. And you see here another child with was prenatally exposed to alcohol, and he has alcohol-related neurodevelopmental disorder. That is to say that he is completely normal with respect to his growth. He's completely normal with respect to his head circumference. His palpebral fissure length is completely normal. His philtrum is completely normal with these normal ridges. He has, however, this Cupid's bow, nice Cupid's bow configuration of his upper lip. So he does not have any of the growth abnormalities of the fetal alcohol syndrome. He does not have these subtle facial features, but he definitely has the neurobehavioral abnormalities, which are quite similar to the neurobehavioral abnormalities that we see in kids with the full-blown fetal alcohol syndrome. And I want to make it very clear to all of you right now that I have a clinic that meets every Friday here in San Diego. And in that clinic, for every child who has been prenatally exposed to alcohol, for every 10 children that I see who have been prenatally exposed to alcohol, only one of those children have the fetal alcohol syndrome, and 9 of those children have what you see here, alcohol-related neurodevelopmental disorder. So the point here is that of the children that you are going to see who have neurodevelopmental problems and has been involved in some kind of criminal behavior, what you're going to see is not the child with the full-blown fetal alcohol syndrome, but the child who looks like this little boy that you see here, which is a child who is completely normal from the standpoint of their growth and in terms of their physical features. So don't be surprised that most of the kids that you see who are affected by this disorder do not, in fact, have the physical features. So this is clearly an invisible disorder. So after diagnosing this disorder, then what? What's the value of diagnosing fetal alcohol spectrum disorder? Why bother diagnosing this disorder? And this is the question that comes up all the time for us when we talk about this disorder. So let me start off by saying that the primary effect of prenatal alcohol exposure is on the developing brain, and the area of the brain that is primarily affected by alcohol is the frontal lobes of the brain, the prefrontal cortex, and you see it sitting right here in this brain. These frontal lobes are considered our emotional control center. They're the home to our personality. It's involved in motor function, problem solving, spontaneity, memory, language, initiation, judgment, impulse control, and social and sexual behavior. So the manifestations of frontal lobe dysfunction are shown, or at least some of them are shown here. And I'm sure, again, Larry is going to go over them in greater detail, but just briefly, problems with executive functions, specific learning problems, memory impairment, visual spatial difficulties, and I think most frequently impairments in self-regulation, both mood or behavioral regulation, attention deficit disorder, hyperactivity, and seriously impaired impulse control. Now, these are the kids that I see so frequently in my clinic, and I will tell you, up until 5 to 8 years ago, when a parent brought their child in with these problems to see me and then asked this question, now what? What are you going to do about it? I would, for the most part, have to say we don't have much to be able to do about it. But that's definitely not the case now. At this point, the greatest amount of research on this disorder is being done on intervention as far as this condition is concerned. And I'll just show you here 2 interventions. One is called, and the one that we use most frequently is called the MILE program. It's a math interactive learning experience. And just very briefly, children with this disorder often have difficulty with math skills. And that results from early and ongoing difficulties with visual spatial learning, working memory, and self-regulation. And based on that, they struggle to master math skills and reasoning, which impact seriously important academic and daily functioning. So parents and teachers in this program And that's the primary focus of this. Parents and teachers are taught about the special educational needs of children with FASDs and instructed on how to incorporate the mild learning concepts into daily life at home and at school. So the focus areas of this program are enhanced communication between parents, caregivers, and teachers and other school staff, teaching self-regulation strategies, teaching of metacognitive or learning strategies, and providing the basis of future math development. I would just say for a minute, and I'm going to show you in a minute, that I think the first real hurdle that these kids have to go through is education. And we have done a lousy job. And when I say we, I mean Doug and Larry and I and everybody else that's working on this disorder. We have not done a very good job in terms of working with and teaching teachers and educators about how to deal with this disorder. And this is a beginning to try to do that. This is a program called Families Moving Forward. It's another program. It's a positive parenting program for children from ages 3 to 13. The sessions last 90 minutes and the overall program lasts 9 to 11 months. And the aims, I'm not going to go through them at to any degree, but I will tell you that the aims are primarily to support parents and help them better understand their children who are affected by this disorder. So the last thing here on this slide as an aim for this program, the Families Moving Forward program, is to reduce the chance that children affected by prenatal alcohol exposure will have secondary disabilities later in life. And this is one of the greatest problems for children who have been prenatally exposed to alcohol. And I'm just showing you here what some of those secondary disabilities are that these children have. So these are problems that a child is not born with and could be ameliorated through better understanding and appropriate intervention. So mental health problems occur in 92% of these kids, disrupted school performance in 42%, trouble with the law in 60%, confinement in 32%, inappropriate sexual behavior in 45%, and alcohol and drug problems in 20%. So clearly a significant number of these kids with trouble who get into trouble with the law. So I want to end by talking a little bit about the early hurdles to overcome for children with this disorder. And the first one, as I just mentioned, relate to problems with the educational system. And I'll just repeat it. We've done a lousy job in terms of this, in terms of helping educators and helping teachers deal with kids in their classroom. It's been a mess. It's a mess. And the second major hurdle is the juvenile justice system. We have done a FASD screening program at the Kearny Mesa or San Diego Juvenile Detention Facility. This was done with the help of the San Diego County Probation Department, the San Diego County Office of the Primary Public Defender, and the UCSD Department of Pediatrics. You see it right there on your right. The screening program lasted from September 2013 through July 2016. All the juveniles were referred through the public defender's office. The parent or guardian signed consent, and the verbal assent from the juvenile was obtained at the time of the screening. The person who screened and the person who did the screening was a nurse practitioner who I had trained over many, many weeks. We got measurements of height, weight, head circumference, palpebral fissure length, and the philtrum. We evaluated the philtrum and upper lip, the ears, the palmar creases, the fingers and elbows, and for heart murmur. And this physical examination that the nurse practitioner did took about 8 minutes, and she then phoned the parent or guardian to get a brief interview about their child, specifically as relating to alcohol consumption during pregnancy. If the screen was positive, the adolescent was then referred to our FASD clinic for a diagnostic assessment. And you see here, we screened 134 kids. 32 of them, or 24%, screened positive and were referred to our clinic. So 24% of these kids screened positive. And in fact, of those kids that screened positive, only 14 of them were actually evaluated by me. The remaining 18 were lost to follow-up. They moved out of state or were a no-show in our clinic. So 2 of the 14, or 86%, were positive for FASD that in fact did get to the clinic. So the screening program was very successful in that 86% of these kids that were screened positive by the nurse practitioner were confirmed to have FAS when they came to our clinic. But we were pretty frustrated that only 14 of the 32 were evaluated by me, and this just tells what happened to these 18 kids that didn't. So basically, if you assume for a minute that all 32 of those kids who screened positive were evaluated by me, and that 24% of them screened positive and were referred to the clinic, then, and that 32% or 100% of the 32 were then evaluated by me, and that 86%, as was the case before, were confirmed to have an FASD, then 27 or 20% of the 134 juvenile screened at the San Diego Juvenile Hall would have an FASD, which I think is in fact about the right number in terms of the prevalence of this disorder in a juvenile hall, although this, to my knowledge, is the only study that's ever been done of this kind. So the importance of follow-up at our clinic is rather obvious. First of all, to provide them in an environment in which their neurodevelopmental problems can be addressed, to provide them with therapists who have specific expertise in dealing with this disorder, to advise and help parents and caregivers to navigate difficulties related to education, and then to provide parents and caregivers access to support programs. So the question is, why is a call of action so important today? First of all, FASD is more common than autism. And I say that based on the study that I just showed you at the beginning of my talk. Secondly, and I haven't mentioned this before, but alcohol is the drug of abuse that has the greatest adverse impact on development of the unborn baby. So it's not opioids, it's not cocaine, it's not methamphetamine or marijuana or heroin. They don't begin to be as much of a problem to the developing fetus as is alcohol. Alcohol is number one. Third reason for this call to action now, to create a collaborative approach for treatment that includes the juvenile justice system, healthcare providers, educators, physicians, therapists, social workers, psychologists, caregivers, and parents. We need to change the culture as far as this disorder is concerned and make people as aware of this disorder as are people aware of another brain-based disorder that's probably double as common as autism spectrum disorder, to make people aware of it as they are aware of autism. And finally, the earlier children with this disorder are identified, the greater the chance that successful intervention programs can be implemented. And I want to stress what Frederick Douglass said: it's easier to build strong children than to repair broken men. And this just shows you broken men from the Pulunsky unit at the Texas Department of Criminal Justice, where 290 men are awaiting execution. And we've now evaluated not 18, but 20 men for possible diagnosis of FAS at 10 different prisons throughout the US. 4 of those have been evaluated here at the Pulunsky unit. And all men were sentenced to death for murder whose lawyer wanted to use a diagnosis of FAS to change their sentence from death to life in prison without the possibility of parole. And here's one of these men. He's 63 years old. He was sentenced to death for murdering his wife. He's of normal height, weight, and head circumference, but look at his philtrum. He has a totally smooth philtrum. There's complete lack of vertical ridges, and look at his upper lip, so thin and lacks those Cupid's bows configuration of his upper lip. And he had obviously severe neurodevelopmental defects. And I just want to end with this man who I saw. This was the first person that I have ever seen on death row. He was born in 1953 in Fort Bragg, North Carolina. He had run-ins with the law at age 10. He's really a poster child as far as this disorder is concerned. He was placed in juvenile detention at 13 years for stealing a car. His mother abandoned him at age 14. He was placed in juvenile detention again at 14 years for stealing another car. At 22 years, he was in prison for manslaughter. He was paroled 3 years later in 1978 at 25 years of age, and that same year he murdered. 2 teenage boys stole their car, held up a bank. He was arrested less than an hour after the robbery, sitting in a car, eating the McDonald's hamburgers that he had stolen from the 2 boys that he and his brother murdered. He was convicted and sentenced to death on 6/3/79, and he was executed at San Quentin's gas chamber on 21/4/1992. And it was the first execution in the state of California since 1967. And I say he's a poster child because nobody identified this man to have the fetal alcohol syndrome until I saw him in 1979, soon before he was actually, I saw him soon before he was executed in 1992 at San Quentin's gas chamber. So, and again, this invisible disorder. And here's a picture of him, and you see him as a young boy here with this very smooth philtrum and a thin vermilion border with a lack of Cupid's bow configuration. So just in summary, the prevalence of this disorder has created clearly a public health crisis. It's being ignored in the United States. Stigma against FASD, which permeates all sectors of our society, is one of the major reasons this disorder is being ignored. And I haven't talked about it, but it's something that I'm very involved in and very, very interested in now, because I think we're never going to be able to prevent this disorder until we can stop stigmatizing women who give birth to affected babies and those babies to the extent that we are. FASD is the #1 recognizable cause of intellectual and developmental disabilities in the US, and alcohol is the drug of abuse that has the greatest impact on fetal development. So thanks very much. I'm going to stop now.
Dr. Jones.
Stop sharing my slides.
Thank you so much. Indeed, as you say, invisible disorder, and it's really the tragic reality that you described, the prevalence of FASD. And so telling when you describe the instances where you screen populations, you not only identify such a significant proportion who are affected, but the fact that none of them have previously been identified, even in the institutions, the settings where they are, where one would hope there could be an opportunity to do so and ameliorate some of their impairments. So thank you. I think what we'd like to do is we'll hold questions until after we hear from the 3 presenters. So please, everyone, as you
could I have a special request? I think Colleen would like to address the specific questions of education, the education questions, and then go on to the next speaker. Would that be feasible?
Oh, absolutely. Yeah.
Okay,
great.
Colleen, go ahead.
Thank you, Tom. I hit a couple of questions in the chat box that seem very pertinent to talk about real quickly, the education-related questions. I just want to remind everybody on the meeting that there is no special education eligibility criteria for FAS. So just because you have a diagnosis from the community does not automatically entitle a student to receive special education services. Now, of course, that information and that diagnosis is very important to communicate to special education staff in their full assessment and evaluation of a student. But a lot of times, as the chat box says, what we see is the school reacting to the behaviors that are manifesting in the classroom. So along with getting an appropriate diagnosis in the community for school-related purposes, just as importantly, we need to know how FAS is manifesting itself in that particular child. That's what's going to give the education system the information they need to fully assess and evaluate and then plan interventions in the classroom for that particular student, because we know FAS looks different in every single student, just like autism looks different in every student. So really that's that community diagnosis piece that's going to help the education component the best. And then there was another question about are we going to have a time to talk about planned interventions and how to serve these students in the education system? And yes, we will, but that's going to be on the May 6th event. We're hoping to get local panelists from different school districts and different providers here in the community to kind of come together and talk about how FASD represents itself in the school systems, how teachers are interacting with those students, interventions that are working, and some of the requirements under federal law for special education services for these kiddos. So please come May 6th, be a part of that, and we'll certainly dig a little bit deeper into that issue. So thank you for the interruption. I just wanted to be sure we were clear on that.
No, Colleen, thank you so much. What a valuable resource you are. I'd love to be sending inquiries to you. You're just year round, but and let's see if Drs. Bird and Wake may touch on that a little bit. I will also just reiterate, always you can come to information@nofast.org. If you have some questions, we'll do our very, very best to direct you to people like Colleen, experts who really can be helpful on those issues in the field and whatever literature may be available. Okay, so next we'll listen to Dr. Bird, and you can, I think you can earn your own PhD in FASD by listening to Dr. Bird, not only because of the depth and of his content, but I know this summer, for instance, Larry, you have a multi-session webinar series going on, and you can learn about that through Dr. Bird and University of North Dakota, and also at NoFast we have the links and everything to those kinds of presentations, and your voluminous papers that are always being published. We use those all the time. So Larry, take it away.
Thank you, Tom. Appreciate that. Are these up so people can see them?
Yes, Dr. Bird.
Great. Okay, oops. So in Texas, you have about 370-some thousand births a year. If 1% of these children have FASD, that's 3,700 a year, 10 a day. If, as Dr. Jones suggested, it's 5%, that's 18,000 a year or 52 a day. So one of the first things I want to address is that the diagnostic capacity of Texas does not have even a fractional capacity to take care of the new cases every year, let alone the existing cases from birth through 18 or from birth through, say, 60 or so. So the number of children with FASD and our capacity to diagnose them in Texas are quite discrepant. When you think of FASD or prenatal alcohol exposure, you want to think of impairment. And it's important to understand that you can have fetal alcohol spectrum disorder and visual impairment. You can have FASD and epilepsy. You can have FASD and ADHD. You can have FASD and intellectual disability, on and on it goes. And very often it's these somewhat better known conditions that make it easier to get FASD diagnosed in these children. So we're going to have two kinds of new data. Some of this is great news, other parts not so good. So we can now say that fetal alcohol spectrum disorder is the leading cause of intellectual disability in the United States. It's the leading cause of mental disorders in children, the leading cause of placement in residential care, the leading cause of placement in juvenile corrections, the leading cause of developmental disability, and the leading cause of learning disabilities in the United States. It's also a common cause of placement in foster care may well be the most common reason for placement in foster care, but we just don't have the quality of data. It's a common cause of infant and childhood mortality. Very important to understand that the majority of these deaths occur before a diagnosis of FASD. It is a tremendous driver of outpatient mental health services, inpatient psychiatric hospitalizations, special ed placements, visual impairment, and impairments in adaptive behavior functioning. One of the reasons we need to be concerned about fetal alcohol spectrum disorder is that it's common, it's fantastically expensive. So by age 18, we've spent about $966,000 per case. By age 50, about $2.5 million. Or another way to look at this that we use a lot is how many years does it take to spend $1 million on a person with a condition? In FASD, it's 18.6 years. The new data, this is just from a couple of weeks ago. The cost of FASD is about $53,600 for a child, about $49,077 per adult per year. And it gives you some comparisons, much higher than ADHD or autism, 20 times higher than asthma, about 538% higher than taking care of a person of the same age with epilepsy. I had some slides to put in about parenting, but this mom made this picture for us of parenting a child with FASD. And I am pretty sure no data can improve on what she's trying to convey to us here. One of the pieces of good news is that we have a randomized control trial about ready to start on a parenting intervention for FASD. We've done 2 pilot phases of this, have most of the funding, and it will be one of the few actual randomized control trials of any kind of intervention on FASD. Incarceration and juvenile corrections. So this is a really fantastic single sentence description of the problems of FASD. You're 19 times more likely to be incarcerated in the juvenile correction system. So when you're talking with someone and they say, well, I don't know why we'd want to diagnose this, we're already doing everything we can. That's just simply not true. Once in these legal systems, these children fare extremely poorly. Here's a study showing that 43% of them had given a false confession, and 2/3 of them were charged based on that false confession. So in response to this and just a huge amount of other stuff, the National Juvenile Defenders Center worked with me, and we've prepared an affidavit which is available on their website for attorneys, parents, families, I suppose prosecutors too, on the impact of FASD and how it affects children and increases their risk for incarceration and the sort of the body of knowledge of what we know about FASD in juvenile corrections. So here's some of the bad news. FASD, sadly, is not a stable disorder. It's quite discontinuous. The pattern is one of increasing severity over the lifespan. And in part, this is due to the increasing demands we have for independence and better judgment as you get older. So we were doing this study in the hopes of figuring out how to minimize the impact of FASD. What we've learned from this is that that's going to be much more difficult than we thought. So the children who see the newborns and infants have very little involvement with them after that. The people who see children with developmental disabilities or developmental disorders, pediatricians, school psychologists, community psychologists, often don't have much to do with adolescents who are adjusting to their impairments and are beginning to access the psychiatric system and receiving a lot of medications. These people rarely have contact with adults 20 through 30, 40 who have these tremendous adaptive deficits, which are going to make living independently difficult. And none of these people typically are involved with FASD in later life, which is mostly a condition of chronic debilitating illness. And so this just is absolutely hot off of the press. And these discontinuous developmental lines here mean that the amount of education, the number of people in service systems we're going to have to pull in is just staggering. We've just recently published a screening tool for fetal alcohol spectrum disorder or neurodevelopmental disorder with prenatal alcohol exposure. Turns out that using this tool, the results are about the same. You can see the typical domains that we have information on here from this screen. 33 items long, it takes 10, 12 minutes to administer. We just got the computerized scoring completed and the manuals are done. And so we'll have a paper manual and an electronic version of this quite soon. I think it's going to be helpful because it addresses these areas up here: cognition, verbal interaction, social learning, juvenile justice, and it has these individual domains underneath there. And these are statistically validated over a long period of time. So I think you'll, those of you that choose to use it will find it very helpful. In this document for the affidavit, I made a list of some of the impairments we see in FASD and their impact in the legal setting. And there's quite a few of these. I think they're going to be made available to you. Just a couple of particular points dealing with juvenile justice. People with FASD are extremely suggestible. Their gullibility is at times hard to measure, and confabulation is a language disorder. It's turned out, I personally never would have thought this was the case, but confabulation is a type of language disorder where through the process of interrogation, people with FASD take facts from these questions and build it into their story. So it increases the complexity of their life. People with FASD, huge rates of adverse childhood experiences, multiple foster home placements, and high rates of victimization and exploitation. It's, I think, worth, if you're in the legal system in some way, thinking about this. This is not my work, and I have neglected to put the person on here, but in any event, there are 5 areas that are very helpful. And when these show up, it's sort of like a legal system screen that you need to be thinking about fetal alcohol spectrum disorder. Dr. Jones pointed out something that's important, and this is a really fantastic study looking at the importance of diagnosis in fetal in people in juvenile corrections. So after their diagnosis, 74% of the people in the study had no new offenses. So they got evaluated for FASD. They were in a program, they got the intervention. They had no probation violations for 6 months. 83% had reduced school suspensions. 100% avoided any future expulsions from school, and 67% improved their attendance at school. So a very, very potent intervention based in large part on the diagnosis leading to improved understanding of the needs of people with FASD in what is quite a difficult population. So I think that was my last slide. Let me just double check this. Yes. So a lot of good news and I think some bad news. The cost, as we get better at capturing all the elements going into the cost, is going up hugely, especially healthcare costs, corrections cost. We do have on the horizon what I believe to be a very promising randomized controlled trial, which will give us some very high quality evidence about what kind of interventions we need to do with parents. And I think some sadder, more complicated news on the complexity of prevention, minimizing secondary disabilities because of the discontinuity as people with this problem proceed through life. So I'll turn this over to Dr. Waite.
And Dr. Waite, before you proceed, Dr. Bird, I just want to add that it really, of course, is beyond concerning when you look at those figures and what they represent, and human lives and the individuals who are affected and then don't get the support that they need. And I can say that those numbers and the economic figures that you help identify are really playing a critical role with lawmakers. You know, even when we see legislators who might not have disability issues as a first priority, they often do understand economic costs and costs to taxpayers. And you know, if that's what it takes for everyone to get on board and be supportive of this issue from a policy standpoint, so be it. So thank you, Dr. Bird. And again, and I would just ask that Dr. Miranda, Colleen, others, please interject if you need to add something here before Dr. Waite proceeds. And I want to remind all of you to, again, be thinking about questions that you have. Please go ahead and put them in the chat. There may be an opportunity to, after Dr. Waite has talked, to use the feature where I think you can raise your hand and acknowledge that you have something to say. I'm not sure if we're able to use that, but nonetheless, be prepared with questions. This is a real opportunity, even if it's just off the specific topics that our experts have presented. Let's get into some greater discussion about the facets of FASD. Dr. Waite, as Colleen said, is the vice chair of NOFAST, so I get to talk with him when he's not busy in clinical setting. And one thing I can say, Doug, very much appreciate is just the vital work and when you're thinking of this issue in child welfare, and also your proactive nature of not settling and not accepting these deficiencies and inadequacies that we've talked about today in terms of lack of diagnostic services and so forth. So thank you for your great work. I look forward to hearing from you now.
Thanks, Tom, and thanks. Great hearing Ken and Larry. Thank you for your presentation. I want to talk a little bit about how I came into learning about FASD, because it certainly wasn't something that was taught to me in medical school. But it was something that was drummed into me because I kept seeing it and didn't understand it when I was working in foster care as a medical director of a foster care agency in New York City. I knew a lot about trauma. I knew a lot about depression and anxiety, lots of other things. But this was something I was seeing where kids were adopted by apparently good parents at birth, after discharge from the hospital, had no histories of trauma or bad upbringing. In fact, in many cases were given exemplary upbringing, and yet had this malignant trajectory that you've heard both Dr. Jones and Dr. Bird describe. And then I remembered about 10-second, a slide that was put up like this, that Dr. Jones, really the person who first discovered this and brought awareness of the effects of alcohol, not only on facial features, but on developmental course. I suddenly remembered that 1-10-second slide, went back, and as I read about it, I was like, oh my God, this is what's going on. And so I want to lead you a little bit through my processing of this. And as a developmental behavioral pediatrician, I consider myself a general pediatrician, but work as a developmental pediatrician in the South Bronx, and work daily with parents who struggle with kids with autism and intellectual disability, and kids with FASD, most of whom are not diagnosed. And how I see this name, fetal alcohol spectrum disorders, whatever area we want to call this in, as a bridge toward what a lot of people have been talking about in the chat. What do we do next? Because for me, a diagnostic name is only as good as it serves to inform our interventions. When I make a diagnosis of an ear infection, it's so I can treat an ear infection. In a case of an FASD, it's so we can begin to work with parents and join in their efforts to make sure their kids get the services they need, as well as educate them on the struggles that we're likely to encounter as we move forward. So Dr. Jones highlighted how issues with facial features that were the initial thing that led us to almost stumble into the effects that alcohol has upon things we can find on physical exam, which is what a syndrome is. When he described fetal alcohol syndrome, we now know that the greater part of fetal alcohol spectrum disorders is behind the face, that like the picture Dr. Bird showed of taking off the face, that this is something that affects the brain. And it's the brain is the area that we have to focus on, because that's what parents come to me for, issues with their problems with their child's behavior and learning. And we also discussed the prevalence of this. I put this together just to give you an idea of when we talk about neurodevelopmental disorders that include things like intellectual disability, autism, FASDs, that FASDs are more common than autism, trisomy 21, Down syndrome, and cerebral palsy combined. So we're talking about something that's tremendous. Now, I can say I've been taught a lot about cerebral palsy, trisomy 21. I learned about that in medical school. I was taught a little bit about autism, but now everybody gets taught about it, all my residents. And we know a lot of kids with ADHD that are taking medications. But the caveat here is that many of the kids I see who are diagnosed with autism have an FASD. They were just never diagnosed with FASD. They had a touch of autism and they kind of outgrew it. Kids with ADHD, as someone brought up in the chat room, what's the difference between ADHD and FASD? What's the relationship? You know, we're dealing with something as complex as the brain. And when we put these words on things, when we're giving these diagnoses, we're artificially trying to read them apart. But that reading apart is to try and inform intervention. And many of the kids that are diagnosed with ADHD, no one has ever asked about prenatal exposure to alcohol. So the questions that people bring up, yes, we got to think about FASDs in kids with ADHD, but they're not being screened. So we're going to talk about that shortly. So whenever you see any of a kid with neurodevelopmental disorders, we have to get a history of prenatal alcohol exposure to see if we can begin looking at finding the areas that this child is going to need help moving forward. This shows the prevalence of binge drinking in America. I looked at Texas's statistics, which were similar to this national average here, 11% pregnant women drinking in the past 30 days, about 4% binge drinking in the past 30 days. A binge drink for a woman is 4 drinks in a sitting. So this is a really, really common thing. But even more common, if you look at the last bullet, is among non-pregnant women. And we know most pregnancies are unplanned. About 50% of pregnancies are unplanned. And the period of time before a woman knows she's pregnant is an area where the brain is developing in that early stages. It's the first thing that develops. So this is an important time where many times if you ask a woman if she drank during pregnancy, she'll say no. But if you break this down further, you can get a history of prenatal alcohol exposure that can begin to inform your diagnosis. But we're going to go into that in a second. So this is how I came into this. We know FASD is very common in foster care. Susan Astley from Washington did a study and looked at the first 1,400 children she diagnosed with an FASD, and 70% of those kids were no longer in their birth home with their birth parents. They had an average of 3 out-of-home placements. Those of you who have adopted someone with an FASD or who are foster parents know that these are kids that have bounced around to multiple foster home placements because they're so difficult to manage. And those of you who have been able to manage, God bless you, because I know how difficult this is. 34% has history of physical abuse, 24% sexually abused. The mental health disorders that Dr. Bird mentioned, 93% had other prenatal alcohol exposures. So if a child is born positive urine toxicology to cocaine or opiates, we gotta think, has that child been exposed to alcohol? So I think that the thing that we need to think about is if a child's born positive urine tox, we have to expand that because as Dr. Jones pointed out, alcohol is the one that really kills brain cells. And yet in a study by Ira Chasnoff in Chicago, an FASD clinic where kids were referred from foster care for evaluation, 80% of the kids that were referred for evaluation who he diagnosed with an FASD had never been diagnosed. And this harkens back to, again, what both Dr. Jones and Dr. Bird highlighted, that these are kids that are not being diagnosed. It's invisible, not because the disabilities are invisible, it's because we're blind. And part of what these educational sections are is to try and get people to begin to see the things that's right in front of their eyes that we all know we see. And many times after these kinds of presentations, people are like, oh my God, so-and-so and so-and-so and so-and-so I used to care for. They probably had this. Yeah. So we talk about a scope of diversity when we talk about foster care, how many kids are in care, but importantly, and this is what Dr. Bird had mentioned, it probably is the most common cause for kids coming into foster care. Just having worked in foster care, most kids come in for neglect. And even though we know there's recordings and the intake that there was substance use exposure, rarely is this asked about alcohol exposure because it's not tested when they do toxicology screenings. And social workers don't always ask about alcohol exposure. They focus on the drugs because those are the hard stuff. Alcohol's legal. But we know many of those children, 61% who come into for neglect, that in many cases, those are never screened for substance use or alcohol. Why did they come in? Oh, they were found wandering the street. Dad and mom were sleeping in that apartment, or they were out somewhere. No one asked about it. So these are really, really important things that never get drilled in. And it's even more difficult when kids are adopted because you get no information. So we talked about the face. Dr. Jones was highlighting the facial features, and Dr. Bird highlighted if you take away the face. Well, this is to remind us that the brain is the first thing to develop. And Dr. Jones has done studies looking at this middle part of the brain called the corpus callosum, that in many children with fetal alcohol exposure is not developed well, or even as in the slide D, not developed, where there's agenesis of the corpus callosum, but also the midline brain structures. And as I'll show you in the next slide, the brain develops in the middle. It starts as a midline process. So everything in the middle is infected not only the corpus callosum, but the frontal cortex, the main part of the brain that gives us insight, judgment, reasoning, impulse control. That's damaged. The cerebellum, the brainstem, all of these midline areas of the brain are developed. And the face develops around the brain. So if you have abnormalities in the midline brain, it's going to be mirrored in the face. All right. And this shows us the brain growing. This is at 28 days embryo. And you can see it's the first thing that develops. The heart's just starting to develop, but the brain is already developing here. You can see the eye there. And these are cells stained blue that have been killed by alcohol. So alcohol kills brain cells through lots of different ways, but it's killing brain cells early on. And if this is a 28-day fetus, that's around the time when people start realizing they're pregnant, unless it was a planned pregnancy. Now, along the frontal cortex, this is a story that is taught to pretty much every medical student about a man who was working, I believe, on the Transcontinental Railroad, using a tamping rod to push dynamite into rock to blow it up so they could nail the railroad into the rock, and had the misfortune of having the tamping rod blown through his frontal cortex and lived. And he stumbled up the stairs to Dr. Harlow's office, who then followed this guy after this traumatic event, because the guy lived and his life was, completely changed. And this, I'm going to read this because this describes what I was seeing in kids in foster care. The equilibrium or balance, so to speak, between his intellectual faculties and animal propensities seems to have been destroyed. That means the frontal cortex. He is fitful, irreverent, indulging at times in the grossest profanity, which was not previously his custom. Now, if that was a kid, they'd call that opposition defiant disorder. Fitful, irreverent, indulging, using profanity to everybody, manifesting but little deference for his fellows, impatient of restraint or advice when it conflicts with his desires. That's impulse control. All right, that's something we see with ADHD. At times, pertinaciously obstinate. That's like not being able to let go. So these kids, when they have temper tantrums, it's really hard to de-escalate them. When they would get fights in the residential center, it was really hard to de-escalate them. They would plot on getting back for days on end. Get capricious and vacillating. This is something we call state regulation. The ability for me, as I'm talking over this, to kind of keep my mental focus and hold my emotions at a steady state. These kids don't have that. They go up and down with their environment. So they need a highly structured, calm setting with reasonable expectations to help them manage their basic emotional regulations. Devising many plans of future operations, which are no sooner arranged than they are abandoned in turn for others appearing more feasible. That's executive function. That's the ability to make a plan, push everything away between you and that plan so that you can get to what you're trying to do. And these kids not only can't get to the goal, but they almost seem to blow up everything in their course on the way. This is a picture of the different parts of the brain that are affected. Basically, every part of the brain. We talked about a lot of these already. I'm not going to go into this too much because I'm time limited. And this is probably the most graphic slide in terms of giving us an idea of what kids struggle with. This is an 18-year-old child. And so I would see these kids in residential. Timmy just graduated, first person in his family to graduate high school, lived through terrible childhood, been in residential for 6 years. And here's Johnny, he likes to write rhymes. He writes rap music. And he talks really well. He uses these fancy words. But if you try to get him to talk to you and engage in a conversation, a back and forth, or express feelings or abstract thoughts, he's at a loss. So he speaks like he's 20. But when I'm talking to him, he takes in like a 6-year-old kid. And so part of the reason he can't use social communication well is it's going in and right out. So many times parents have to say, how many times do I have to say this? Are you deaf? Yeah, that's the problem. It's auditory processing. It's not getting in. So people hear his good language at 20 years and they say, well, you should be able to understand what I said. You speak really well. But he's hearing like a first grader. Money time concept, 3 years, 8 years, that's a third grader. Emotional maturity, 6 years, that's a second grader. Social skills, 7 years, that's a second grader. So I tell Johnny, you're 18 years old. We just got you a job at the Getty station. We got you a subsidized place to live. You graduated high school, you're amazing. You're going to get a stipend from the agency for $200 to pay your rent, food. You're going to get money from your job. Good luck. So he goes out there. He's got to get up at 6 to get to work. He can't yell at his boss. If his boss yells at him as he's late, he's got to get an hour for lunch. He comes back late. He loses his job, can't pay his rent. He's on the streets. And the next step, Dr. Burns and Dr. Bird have well described, is it's almost like the malignant, inevitable trajectory to those of us who care for these kids. How can we stop this trajectory? So this gets into something that Billy Edwards and Steve Greenspan had dubbed intellectual disability equivalence, because a lot of these kids have normal intellectual ability. I have a guy that I saw when he was 30, who's got an IQ of 130, who stumbled through the private elite private schools on the Upper East Side of Manhattan. His parents adopted him. They live on Fifth Avenue. They're loaded. He couldn't do anything. He couldn't understand when people are talking to him. He'd be like, yeah, yeah, yeah. And he had no idea what they were saying. So he had an IQ of 130, but when you looked at his adaptive function, his actual ability to function in the world, it was like 60. So you can have a really good IQ, but not be able to function in the day-to-day world. So one of the issues we have in trying to get services for these kids in the school is, well, Timmy could do better if only he tried harder. He scored, his IQ is 100, but look at his achievement testing is in the 70s. So he just needs to pay attention more. He needs to listen more. He's got auditory comprehension issues. He does have issues with attention, but he's got so much more going on. So adaptive function is really an important piece to look at. And this is where we can get into saying, he doesn't have intellectual disability based on cognition, but based on adaptive function, he does. And the DSM-5 highlights the importance of adaptive function in the diagnosis of intellectual disability. So how do we screen for prenatal alcohol exposure? This is something that we put together for pediatricians. And I'm going to share it with you because I think this is the area that people are afraid to tread on. And Dr. Jones and Dr. Bird mentioned stigma. And this is what we're talking about. This drinking during pregnancy, everybody knows you're not supposed to do it, right? And alcoholism itself is a disease of denial, of people afraid to talk about their problems. And if you're a woman and you're pregnant and you're drinking, it's really hard to bring this to anybody's attention because you feel even more bad because you know you might be hurting your fetus. So one way to get around this is to start with how far into your pregnancy were you when you found out you were pregnant? Oh, I was about 6 to 8 weeks. I've been amazed to sometimes hear people say, I didn't know until I gave birth. But many people say, oh, 4 months, but you get a start date when they found out they were pregnant. Before you knew you were pregnant, how many drinks of alcohol, beer, wine did you drink? And you can kind of begin to quantify this per day, per week, depending on what you're getting back from the parent. After you found out you're pregnant, how much did you drink? And always say how much, because you don't want to just say, did you drink? How much did you drink? And then you can get into the other substances of weed, cocaine, opioids, and after pregnancy, how much did they use? And I put this in as 13 drinks per month, which is kind of used for the DSM diagnosis of neurodevelopmental disorders associated with prenatal alcohol exposure, or 2 or more drinks at one time. No one knows how much alcohol is appropriate, all right? But the point is you're beginning to ask about this, and you'll be amazed once you start asking about it, how many people will disclose it to you if you ask it in this way. And you do it in a non-judgmental way. People will be as comfortable answering it as you will be asking it. So practice helps a lot. But in the absence of getting that, if the child's adopted or they're in foster care and you can't find the mother, these are other things that are often suggestive. I get a lot of kids coming in for developmental evals that with the grandmother or aunt. They're not living with their mother, right? Early childhood school behavioral difficulties. This is the classic presentation: speech delay, aggressive behavior. They're getting kicked out of kindergarten, kicked out of day school. 5 different day schools don't want them. All of those kinds of things. But further down, 2 or more psych diagnoses. So we brought up ADHD in the chat box, but ADHD, ODD, conduct disorder. Oh, he's been hospitalized. His moods go up and down. He's got bipolar disorder. Oh, he talks to himself sometimes. He's got psychosis. All of these things, this alphabet soup, it's classic for FASDs because the brain itself is defected. is affected, right? It's brain damage. And so they look like they've got a smattering of everything from the DSM. If you see that, you got to ask about history of prenatal alcohol exposure, right? 2 or more past psych hospitalizations, a sibling with an FASD. This runs in families. And by the way, if the kid has it, the mom often might have been exposed. So ask about that as well. I'm going to move faster now. The areas of the brain that are affected by diversity that Dr. Bird brought up, these kids are at high risk for, are the same areas that are affected by alcohol. So this is a stack on stack. It's almost like what I call double jeopardy, that you have the same areas of the brain being affected. So when you put them together, you have this kind of effect with trauma, no FASD, trauma with FASD, large changes in attention, memory, receptive language, expressive language. Protective factors. So this is getting into intervention. We got to get them diagnosed, because having a stable home, and part of getting a stable home with these kids is teaching people what FASDs are, that what they're seeing isn't because the kid is a bad kid. The parents know they're not a bad kid. They just know they do these crazy things. It's that they can't do it, that they have a disability, right? It's not that they won't, it's that they can't. So switching that and educating about the issues the child's having and problem solving on fixing this. And ironically, having facial features is a protective factor because they tend to get diagnosed sooner, all right? And getting them help and helping the families. And this is one of the most important things when we talk about interventions, because you'll see in the middle, the middle circle, the learner can do without any help. The next circle out, he can do with assistance or guidance. The last circle, he can't do. So I see a lot of kids who are in 7th grade, right? And when you look at their testing, they show that they're functioning like a 2nd grade level. So what do? Well, he needs to repeat 7th grade because he's functioning at a 2nd grade level. But they don't change. They don't give him more services. But part of what we do with disability is change the expectations. Well, he can't function at 7th grade. He's functioning, let's say, at 2nd grade. So let's bring our expectations down to 3rd or 4th grade, and let's give him some help. So he can actually feel like he can do something, right? Now, with a lot of kids with issues, when I was working in foster care, I could say, as clear as day, I can see a place in the world for you. A place where you can be happy, where you bring good things to the world. I don't always feel like I can say that to kids with FASDs. And the reason I don't is because I'm trying to get people to understand the gap that we need to fill is tremendous. So a lot of this is advocacy. This is my dream of what that might look like. All of these people know what FASD is, just like with autism. Oh yeah, this kid's got autism, we do this, this, and this. They would know what to do with FASDs. The Family First Prevention Services Act passed in 2018 gives us an opportunity to do this because it focuses on parents with substance use issues, largely in response to the opioid epidemic. But again, we got to link this with alcohol exposure. Policy, Tom Donaldson talked about the new bill that's in Congress, the FASD Respect Act. This is a disability, not a disorder. All right, a disorder is a way we describe things like bipolar disorder, but it also means that we don't really know what's causing it. But when we look at it, the outcome of having an FASD is disability. Disability implies under IDEA that these kids need services. It's a law, it's a federal law. I think that's where we need to move toward to get these services. And this is the last word. I think resilience, kids amaze me. And kids I've worked with that have FASD amaze me. Parents amaze me. And then how they get their kids, and if they get educated on this, it clicks, then they are the best advocates. They go into school, and I wouldn't want to be on the other side of that desk. They're really the best advocates. So we should be able to all join together to begin to get this on people's radar so that we can get these kids services. And that's all I got. Thank you.
Terrific talk, Dr. Wade. Thank you so much, and fantastic, all of you. As wonderful as it is, I think we miss a little bit of the best quality of each of you three gentlemen, and that is, I think the passion and the empathy for the FASD lived condition, and really that determination to see that FASD becomes part of the public and professional consciousness. So Thank you for all you're doing. Let me go back to Colleen and Rajesh for the best use of the remaining time today. Thank you, everyone.
Okay, it looks like the chat has been very active in this intervening period, and a lot of really interesting and important questions have been asked. And what I'm going to try and do is to kind of break the questions down into groupings and maybe start off with a leader question in that area and then fill it in. And for any of the speakers, if you're, if you just jump in and address these questions. So one has to do with the co-use of other substances and whether that can be helpful in diagnosis or whether they are other substances can have similar effects. So I'll start with the last question in the chat that sort of represents this. So this is from Dr. Karen Rogers, who is in the Lubbock area. Question for presenters: I assess regularly for FAS and FASD. If I can get the birth mother to admit to drugs during pregnancy, but they are reluctant to admit alcohol, or CPS paperwork says multiple drugs during, no documentation of alcohol, and you cannot contact the mother, then how do you integrate that into the evaluation? Especially if the infant is small for growth and has small FOC and facial features, neurodevelopmental deficits. Can you use exposure to other drugs as a piece of information that might help you?
Dr. Miranda, can you mute her?
Oh, yes. Sorry. My apologies. Yes, I did mute. Would any of Dr. Waite or Jones or Bird?
So one of the issues is that, of course, in the majority of cases, it's poly-substance exposure. And alcohol and cigarettes are very commonly paired together. So not all smokers drink, but most heavy drinkers smoke. Hospitals, clinics screen for this common panel of drugs, but they do not screen for alcohol. And so it comes down to, as Doug, I think, said this perfectly, the more comfortable you are at talking with a mom about this, the more you're going to have her share with you.
I don't know where the chat is.
When we teach our students, we avoid using the words admit to or things like that. This is a process of sharing information. And so I think Dr. Waite's strategy of when were you pregnant? What did you drink before you were pregnant? Very good.
And how can one assess this information if the birth mother is not present in a child?
Let me just address that too, because this happens all the time in foster care. I've even had kids where they meet criteria for FAS and the mom, is emphatic she only used cocaine. All right, maybe she did, right? Maybe she did. But this child has a neurodevelopmental disorder. And there's a category called neurodevelopmental disorder, NOS, not otherwise specified, just like there is in the DSM neurodevelopmental disorder associated with prenatal alcohol exposure. We can just call this a neurodevelopmental disorder. If they meet criteria for ADHD or autism or mild intellectual disorder, we could do that. But again, we're only doing this to get services. So you're going to lose this if you start getting into, well, you must have used it, you were using, you can't get into that ground. And I think the same thing comes up with adoptions where you don't have that history, or with the mom is not around, or she died. That ultimately the only reason we're making this diagnosis is to get services. You can suspect it, but you can't, at the stage where we're at now, because we don't have a biological marker, diagnose an FASD unless you have a history of prenatal alcohol exposure, unless it's FAS. So I get where you're coming from, but I would argue it doesn't matter. If you think this is what's going on, you know what services to get. You can treat him like he's got FASD.
So just to be contrary, I think it's hugely important to identify this. because we're talking about two people. One, the infant. The second is the mother. Women who have a child with FASD have a huge mortality risk. In addition to that, let's say you die at 35 from some version of alcohol problems, accident, liver disease, whatever it is. You also have about 25% of that is going to be a period of disability. So a huge portion of their life is going to be consumed with this. If we don't sit down with these moms, try to forge a relationship, get to know them, have them get to know us, then we're very likely soon to be seeing their second, third, fourth children for evaluation. So figuring out what this woman is using is important. Now, I would agree with Dr. Waite that it is really difficult. It might well be useful for us to proceed on two tracks. Can we learn this? No. If we can't, then what can we do? But I do think we want to know it if we can.
And they're not mutually exclusive. I
Right.
agree with you, Larry, because many times part of forging the relationship is to forge the relationship because you both want to help the kid. So, you know, you can start doing this, and don't be surprised if that mom comes back and tells you she was using later on. But it can be a work in progress. It doesn't have to be, this is the evaluation, this is it. What I'm saying is move on and get the kids services. And that is the process, I think, that Dr. Bird's highlighting. You're going to build a trust.
Dr. Jones, any additional thoughts?
No, I don't have any additional thoughts as far as what the two of them are saying. I totally agree with them. I think that one of the things, though, that we need to think about is specifically what Larry said, which is basically we as Doug is focused on, we need to get services. And there's absolutely no question about that. And that's the number one thing we've got to get. But we've also got to identify whether a woman is drinking alcohol or not. And I think that's true. And I think it's going to be more and more true in terms of developing interventions that are specific for this disorder. But number one, I think it's true in terms of recurrence, because if you can identify that a baby's problem is in fact due specifically to alcohol, you then can focus on that particular drug in terms of talking to her about having another child who is affected. And if you can't do that, she loses that. And I think recurrence is a huge issue.
And then as a follow-up, one of the other questions in the chat sort of extends it to other drugs like opioids, for example. Can opioids, to your knowledge, mimic the effects of prenatal alcohol? Or if somebody has an opioid use disorder, is it likely that they're also co-using alcohol, and it's alcohol that is the agent that's creating adverse outcomes?
Well, at this point, there is really absolutely no evidence that opioid exposure during pregnancy leads to problems in the developing fetus. So that's definitely one issue that we are lacking at the present time. There clearly are some very good animal data that indicate that smoking marijuana and drinking alcohol creates a problem that's worse than just drinking alcohol or just drinking alcohol by itself. So there's definitely synergistic effect of marijuana and alcohol during pregnancy. But I don't know of anybody that's shown anything related to opioids, despite the fact that there's been incredible talk about that.
And then I could add that with some other drugs like cocaine, for example, the metabolism can create new compounds like cocaethylene, which are also biologically active. And so those can have their own effects as well if you're co-using cocaine and ethanol. The other issue that Dr. Waite referred to is the chat in the chat was really the interest in the overlap in the diagnosis between ADHD and FASD. And to what extent are they co-occurring diagnoses? And then a related issue that was raised in the chat is, do ADHD medications help a child with an FASD? So first of all, the co-occurring diagnosis, are they the same thing, or are they really different?
Well, you two, the other two, know I think a lot more about this than I do, but I'll start the discussion. I think that this is a major issue from a legal standpoint right now, because I can't remember what circuit court of appeals denied the fetal alcohol spectrum disorder diagnosis in terms of mitigating alcohol, prenatal exposure to alcohol as a reason to put somebody to death, because they said that it's exactly the same as ADHD, which this individual had as well. And ADHD is certainly not something that we would think would be important in terms of a mitigating issue as far as the death penalty is concerned. So I think that this is an even more critical issue than we have thought of before. But there's absolutely no question that the majority of children that I see with the fetal alcohol spectrum disorder have attention deficit hyperactivity, and they have problems with impulse control. But I don't think that so I think that you can say that hyperactivity and problems with attention are very significant problems and occur very frequently in kids that have been prenatally exposed to alcohol and in fact have FASD as their real diagnosis.
Yeah, I think that, again, I think these are artificial terms that we're throwing out. They are based in science, but we also have to be humble enough to realize this is a kid. It's a complex brain going on here. And Dr. Bird has done a lot of studies about different psychiatric conditions related associated with FASD, so he could talk on that. But I can talk to the fact that even kids with autism, intellectual disability are diagnosed with ADHD all the time and are started on medications. Whether or not they work, there's a common dictum in the FASD literature that medications are not often as effective. Whereas with ADHD, you give a child an ADHD medicine, it's like a light goes on. A lot of times with FASD, you feel like you're just thrown into the ocean. So, I think given the desperation that families and kids experience with this disorder, a trial on ADHD medicine is pretty a benign thing to try, and so I don't think I would think too much about having both of them on there. But the FASD is more important because it highlights the brain damage and that this is not just attention.
In the chat, Julia Rivera says, in my experience as a parent and that of many other parents, the stimulant ADHD medications exacerbate regulation problems with kids with FASD.
I think that's a good point. And I see this more and more as an issue with emotional regulation, meaning that we try treating this as ADHD, but many kids with FASD do get worse, partially because there's a large anxiety component, but also because their main issue is mood regulation. So I think treating mood regulation often works better.
And then there's a question with respect to how to get people to accept services. And this is a question, if I can paraphrase, about somebody talking about their grandchild that has evidence of FASD and how to get the mother to be willing to accept getting help and to look for getting help and to seek services.
So
any thoughts about how to recruit the birth mother into this process if that person is not willing?
So one of the key building blocks of substance use disorders is denial. Denial that I have a problem, denial that you recognize it, denial that it could cause problems for my family, my husband, my children, at work. And so when you approach these problems, just understanding that simple concept, that denial is a key part of this. And in most cases, confronting people is not going to be helpful, but reasoning with them, talking about options so that we try not to get them pinned into a corner where denial is going to turn into sort of belligerent refusal. And that's a strength most grandparents have, is that as parents like myself are struggling to figure out how to do it, they offer us these little tips. They're supportive. They realize it takes a while. And I think that's really the approach that's going to be most optimal for in most cases.
I see that Colleen has put into the chat the linkage to the Ninth Circuit court case for anybody that's interested in. A question that was sent to me relates to the diagnosis of autism spectrum versus FASD. A similar question. Janice says, I've heard that both ASD and FASD cannot co-occur because ASD is an overgrowth of cells and FASD is the opposite. Of course, we know that it is diagnosed frequently with FASD. Any thoughts?
You didn't hear me laugh when you're reading that. I just think it's ridiculous.
Mhm.
I mean, kids with FASDs have difficulties in speech. They often are speech delayed, which is one of the main reasons kids end up getting diagnosed with autism, if they have speech delay. They have difficulties with social impairment and social interactions. Kids with FASDs tend to be overly friendly. So they'll go from the playground with a stranger. Kids with autism tend to be more isolative. But the spectrum of what people are calling autism now is so wide, since this new autism spectrum disorder, they pretty much anybody who goes to be evaluated with the speech delay, who has any impairment at all in social interactions, is going to come out with a diagnosis of autism. But I would argue that the trajectory of FASD and autism is very different.
I think Dr. Waite's point is a good one, that in most cases you spend a little time with this child in your office and your clinical intuition sort of suggests I'm leaning this way or that way. There are cases where children have both, just based on statistical probability. And the question, I think, is flawed, because I don't think one excludes the other. It's like this drive that some places have to say, well, if you have Down syndrome or DiGeorge syndrome or Dubowitz syndrome or Williams syndrome, you can't have fetal alcohol spectrum disorder. To me, that's ridiculous, because I know of nothing about other genetic disorders that protects you from the effects of prenatal alcohol exposure. So I think they could occur together. They probably do fairly often. We don't see it that much. We do see some, but not that much.
And here's a question about how the school systems can help. So this is a question from Basilio. How can school counselors and school social workers look out for, so that they don't get confused with ADHD? So I guess what can school counselors do to help with this process of initiating a diagnosis?
I'll turn that over to my colleagues.
And I'll turn this over to Doug.
Great. Well, I don't know that school counselors are the place to start with this. I think even in foster care, we have an extra hurdle because we're dealing with a mom who, like in the case where people were talking about, she admit using drugs but not alcohol. She's trying to get her kids back. I would lie about whether I used alcohol during pregnancy because I want my kid back, right? In school, there's a whole other level of judgment that can come into this. I think that counselors can be good to identify kids who are having issues beyond just emotional issues. I think many kids with neurodevelopmental disorders like FASD, the people go on what they're seeing in the behavior and missing the underlying impairments. And if we can get counselors in schools to be more adept at understanding that not all things are psychiatric disorders, that they can be brain-based disorders like FASD, and get them referred and get somebody that can actually figure this out, that would be a more appropriate path, I think, is referral to somebody like a developmental pediatrician. Because I think the risk is them just going forward and being diagnosed with psychiatric diagnosis and the bigger underlying issues being missed.
And if I may interject, for the education piece, I agree. I think that, school diagnosticians, counselors, and other special education staff, they're not purposefully not serving kids that are on this spectrum. They just simply don't know the resources to get the appropriate diagnosis. So anytime any of these local chapters of alliances or of NoFASD can get before a school district and start educating the people that are making these special education decisions about how to get the appropriate diagnosis, what that looks like, what that would open doors for in the community, we need to be talking to those people at the school district level, because that's really where so many of these interventions, as far as the behavioral challenges and the manifestations in the classroom, are going to come from. It's simply educating them, just like today, getting that information out to school districts.
And another question that sort of generally is a theme that's been coming up again, and is what is the availability of resources? And that is come up in different forms in the chat in Texas, whether it's with the school systems or for the parents. And I don't know who would like to field that.
I didn't get the question, Rajesh.
The general theme in the chat has been the availability of resources to help parents or school systems, help a person with an FASD.
So I'm not an expert on services in Texas, but at least in the Lubbock community, Dr. Rogers is there. So that's a tremendous benefit compared to most places who don't have a single person who's willing to evaluate somebody for FASD. Just a note, we only have about 1% of these kids diagnosed. And we have far less of the adults diagnosed than that. So the amount of capacity that we have to make available is just huge. And I don't see a way to do this ever without getting pediatricians, child psychiatrists, child neurologists, and psychologists, people like that, involved in the diagnosis of this. There's just hundreds of times too many to ever refer to multidisciplinary clinics. This is something that routine health professionals have to pick up and start doing, like they do for asthma, diabetes, autism, visual impairment, on and on it goes. This is not more complicated than that.
I totally agree with you, Larry. And I really do believe that we need a cultural change as far as this disorder. And I think that your point about the same way we need to approach diabetes and asthma and all these other conditions, we need to be doing as far as this disorder is concerned. But there is one overriding thing here, and that is stigma. And I didn't talk about it today. Somebody mentioned it, and I had mentioned it as well. But I don't think we're ever going to be able to get that cultural change occur. I don't think we're ever going to be able to get people working together as far as this disorder is concerned. I don't think that we are going to have an awareness as far as this disorder is concerned if we don't do something to change the absolutely devastating, overwhelming extent to which this disorder is stigmatized. This disorder is stigmatized by the public more than a woman in jail. It's stigmatized more than mental health problems. It's stigmatized more than drug abuse kinds of problems. It's number one in terms of stigmatization of different groups in our society. And we have shown that in 3 studies that we have done and published. So I think it's a devastating thing. I think that we absolutely have to face it. It's just amazing to think that, I go out and try to get funding for programs as far as this condition is concerned. And I get people's eyes roll back when I start talking about this disorder. And when you're facing money and funding and service help and everything else for children with childhood cancer and children with heart defects and so forth and so on, and you try to do the same thing for this disorder, I think we're going to have a horrible problem dealing with this the way you suggest, which I am absolutely 100% in agreement with if we don't do something about stigma.
But let's also not forget that where autism is today, 30 years ago, there was no services for kids with autism. When I was in medical school, I didn't get training on autism.
Yep.
And the only reason there's services in place for autism now is because parents gathered together. They said, my kid has a neurological problem. He needs services, and they fought like hell. And I think that we cannot also overestimate the importance of just being with parents in the process of trying to have them get help and educate them about the issues that their child has and the areas that we might be able to get services. Because parents are like warriors when they go into school, and you can get educational lawyers, you can get a whole army around you. But I think that we're going to have to change this really legally. I do not think there's going to be a social consensus on this. I think it's going to have to be pushed through an educational law. But from what I've read in the chats, you guys are blessed with having all FASDs covered under IDEA, not in New York. You have to have FAS, as it was defined in 1973, to get qualified for services, not any other FASD. So that's what we're up against in New York State.
Yeah, I think you're really lucky too. You're lucky to have a group of people who come to a meeting like this and ask the questions that you've been asking. I think it's fantastic.
I think that's very well said. We're really fortunate to have people that care. One issue that was raised is to remind us that FASD does last a lifetime, and children grow up to be adults, and those adults need services as well. I'm just going to just mention at this time that I'm going to save the chat log, and the video recording is being saved, and I'll hand it over to Colleen when all of this is done for distribution as she wishes. Colleen, do you have any things? I think we've sort of covered the major points in the questions.
I think so, Dr. Miranda, and I certainly appreciate you keeping an eye on that. It was a very active chat. I'd love to see that. I appreciate everybody's attendance today, and certainly thank you to our presenters for all of your wealth of information and dedication to this topic. I put my email in the chat box multiple times. Please reach out to me with any additional questions. I'll do my best to funnel them to the right person and get those answered for you. And certainly earmark May 6th on your calendars. It's going to be a great day with lots of information, and it'll give us the time to go deeper into some of these issues that have come up in the chat box. We appreciate your attendance, and thank you again to the 3 of you, and to Tom, thank you very much. Appreciate all of you guys, and have a good rest of your afternoon.
Thank you.
Colleen.
Thank you.
Thanks, Rajesh.
Thank you. It was a real pleasure.